The EDTA from the first tube can contaminate the second.
Which completely alters the potassium or calcium levels in the results.
Exactly. Which means the doctor might diagnose a severe electrolyte imbalance that doesn't actually exist simply because the MA drew the purple tube before the red tube.
That is terrifying.
It is. So mentioning the order of draw proves your technical training is deeply ingrained. But you take it a step further to explicitly address the CLIA quality control they asked about.
What's the next step?
You note that you ensure all equipment is unexpired and that the site is prepared correctly to avoid hemolysis.
Hemolysis. That is a fantastic vocabulary word to drop in an interview. But again, let's look at the physical reality behind the term. Hemolysis is the literal breaking open of red blood cells. How does an MA's technique actually cause that?
Oh, several ways. It can happen if you leave the tourniquet on too long, causing blood to pool.
Okay.
It can happen if you use a needle gauge that is too small, which creates too much shear force and literally shreds the cells as they are pulled into the vacuum tube.
Like pulling them through a tiny straw.
Exactly. Or it can happen if you don't let the alcohol wipe dry completely before inserting the needle.
And what happens when the lab gets those shredded cells?
When the lab receives a hemolyzed sample, the serum is pink or red instead of yellow. They will reject it immediately.
And when the lab rejects it, the MA has to call the patient, who has already gone home, and tell them they have to come back in and get stuck with a needle all over again.
It is a nightmare for patient satisfaction, and the clinic loses money.
So by assuring the interviewer that you actively work to avoid hemolysis, you are telling them you understand the mechanics of blood collection at a cellular level.
Yes. But I want to highlight something really impressive about this specific answer in your prep document.
What's he?
You don't just stay bogged down in the hard science. You weave your unique background right back into the protocol.
The salon background.
Right. You finish the answer by saying, beyond the technical, I use the calm, reassuring approach from my background to help patients who may be needle phobic, ensuring they are positioned safely before I begin.
I love that. That is the salon owner coming out.
Ah.
Because you can have all the technical skill in the world, but if the patient is hyperventilating and yanking their arm away, you can't get the draw.
You'll miss the vein every time.
You are reminding the interviewer that you manage the physical sample and the patient's psychological state simultaneously.
It's a beautifully holistic approach.
And we see this same dual-focused technical precision paired with patient care in your answer regarding immunizations. Question 6. The interviewer asks, can you walk us through your process for giving an intramuscular or IM injection?
Administering medication is easily one of the highest risk tasks an MA performs on a daily basis.
Yeah, you can't uninject a medication.
Once it's in, it's in. So your answer needs to sound like an aviation pre-flight checklist.
Unbreakable routine.
It does. You start by deploying a great industry term. You say, first, I perform the triple check of the medication against the physician's order.
The triple check. That's checking the vial when you pull it from the cabinet, checking it when you draw it up into the syringe, and checking it one last time before you actually administer it to the patient.
It's an airtight system.
Yes. And from there, you move into the anatomical specifics. You mentioned locating the appropriate landmark, usually the deltoid for adults, to ensure I'm hitting the muscle and avoiding nerves or bone.
You are proactively reassuring them that you understand the physical risks of doing it wrong. Hitting the sciatic or radial nerve with the needle can cause permanent damage.
But the part of this answer that really sets you apart from a standard entry-level candidate is your inclusion of the Z-track method.
Oh, the Z-track. This is huge.
You say, I use the Z-track method when appropriate to reduce irritation. Let's break down why that specific detail is such a strong strategic play for Michelle.
Well, the Z-track method requires extra effort and mindfulness. It involves using your non-dominant hand to pull the patient's skin and subcutaneous tissue laterally to the side before inserting the needle.
So you're physically displacing the layers of tissue.
Yes. You inject the medication deep into the muscle, leave the needle in for a few seconds, withdraw it, and then release the skin.
And the physical mechanics of releasing that skin creates a zigzag path, the Z-track, which essentially seals the puncture in the muscle layer, preventing the medication from leaking back up into the subcutaneous tissue.
Exactly. Certain medications, like iron injections or certain antibiotics, are highly irritating or can even stain the skin if they leak into those upper layers.
It causes the patient significant unnecessary pain.
Exactly. By explicitly stating that you utilize the Z-track method, you are signaling that your focus extends beyond simply executing the physician's order. You are actively utilizing advanced techniques to mitigate patient discomfort and prevent complications.
You're showing you care about what happens after they leave the clinic.
And your follow-through in this answer is just as rigorous. You state, "Finally, I stay with the patient for a moment to monitor for any immediate adverse reactions and document the site, lot number, and expiration date immediately."
This proves you view the procedure as a complete closed loop. You don't just administer the injection and immediately rush to the next room.
You monitor for anaphylaxis.
Right. And you document the lot number so that if there is a recall on that specific batch of vaccines 6 months later, the clinic's records are perfectly clear.
It is regulatory level attention to detail.
Okay, so up to this point, you've proven that you can handle the clinical tasks perfectly. You know your anatomy, you know your lab protocols, you know your medication
The
administration.
clinical foundation is rock solid.
But any MA can perform well in a quiet, empty classroom.
Sure.
The reality of an outpatient medical office is that it's often chaotic, understaffed, and running behind schedule. This brings us to a crucial part of the interview, proving you are unshakable.
The situational questions. This is where interviewers try to induce a little bit of stress just to see how you react.
Right. Question 7. The scenario is set. How do you prioritize when you have a patient in a room, a phone ringing, and a physician asking for a file?
It's the classic triple threat scenario.
If you just say, "I'd try to do it all at once," you sound naive. If you say, "I'd ignore the phone," you sound disorganized.
This is where your 20 years of business ownership becomes your absolute trump card.
How should Michelle leverage her background here without sounding like she's dismissing the clinical nature of the problem?
You lead with the mindset, not the medical details. Your strategy begins by calmly asserting your baseline. You say, "My years of managing a busy salon and a team have made multitasking second nature."
You instantly reframe the chaos.
Yes. For a new grad, 3 things happening at once is an emergency. For a salon manager on a Saturday afternoon, 3 things happening at once is just 2 p.m.
You are establishing that chaos is your comfort zone.
Exactly.
But you still have to answer the clinical prioritization question. How do you triage those 3 specific demands?
You lay down an absolute unshakable rule. My priority is always the patient currently in front of me, ensuring their immediate safety and needs are met.
This is the only correct answer in healthcare.
The only one. The patient in the room is your primary legal and ethical responsibility. You cannot abandon a blood draw or an EKG prep to answer a phone.
But you also can't just ignore the physician who is asking for a file.
Yeah.
So how do you manage the environment without leaving the patient?
You deploy a communication strategy. You explain, "I've learned to triage tasks. I would briefly acknowledge the physician to let them know I've heard the request and will have it in 60 seconds, then finish my immediate clinical task with the patient."
I want to spend some time on this 60-second rule. Because from a delivery and coaching standpoint, this is pure gold. When Michelle is role-playing this in the interview, why is that verbal acknowledgement so critical?
It comes down to managing the anxiety of the people around you. When a doctor asks for a file and you say nothing because you are focused on the patient, the doctor assumes you didn't hear them, or worse, that you were ignoring them.
And their frustration spikes.
They might interrupt you again, but if you make quick eye contact and say, "I have 1 more minute with Mr. Smith, doctor, and I will grab that file immediately," you have controlled the flow of information. You've managed their expectations.
You're projecting calm control. And you tie it all together beautifully with your concluding statement in this answer. You say, "I stay composed by keeping a mental checklist and never letting the rush compromise the accuracy of my data collection."
That is the ultimate reassurance for the clinic manager. You are explicitly guaranteeing that no matter how loud the waiting room gets or how far behind the schedule falls, your clinical precision will not degrade.
You will not misread a blood pressure or mislabel a lab tube just because you are in a hurry.
Never.
Which brings us to the final piece of the puzzle. Question 3. We've talked about how you handle tasks and how you handle chaos. Now let's look at how you function within the broader ecosystem of the multidisciplinary team.
Right, the communication question.
The question asks, how do you communicate the needs of a patient to a multidisciplinary team, especially when the clinic is busy?
This question explores your understanding of the MA's unique position in the clinic hierarchy. Your answer frames it with a fantastic metaphor. You say, "I view the MA as the bridge between the patient and the provider."
The bridge. Let's dive into the reality of what that means on the clinic floor. Because patients interact very differently with different layers of the staff, don't they?
They absolutely do. A patient might be stoic and dismissive when checking in at the front desk. They might be intimidated and quiet when the physician is actually in the room.
But the medical assistant occupies a unique, highly intimate middle ground.
You are alone in the room with them, often performing physical tags, taking their blood pressure, prepping them for a procedure. It's in those quiet moments that patients confess things.
And your strategy utilizes a perfect example of this phenomenon. You note, if a patient shares a concern during intake that wasn't on the chart, like a new symptom or anxiety about a procedure,
Mm.
I make it a priority to relay that to the physician or nurse immediately and concisely.
Let's connect this to your salon background again. For 20 years, you have created environments where people feel comfortable disclosing personal information to you while you work.
You have an ingrained intuition for making people feel heard.
When a patient sitting on the exam table suddenly admits they've been having chest tightness, but they were too embarrassed to tell the receptionist, your background allows you to handle that disclosure without panicking.
But how do you actually execute the communication part of that? How does the bridge relay that information to a doctor who is already stressed and running 15 minutes late?
That is where your executive functioning kicks in. As your answer states, you know how to triage information so that the most critical needs are addressed first without disrupting the overall clinic flow.
You don't write a novel in the chart and you don't corner the doctor for a 5-minute story.
No. You step out of the room, find the physician, and deliver a 10-second, high-yield summary. You say, "Doctor, Mrs. Davis is prepped in room 3. Her vitals are stable, but she just mentioned she experienced some chest tightness yesterday that isn't in her intake notes. I wanted you to be aware before you went in."
It is concise, it is actionable, and it fundamentally alters the quality of care the physician can provide. You possess a practiced, deeply ingrained composure that simply cannot be taught in a 6-month certification program.
And that, Michelle, is the entire strategic core of your interview preparation.
Let's take a step back and look at the massive narrative we've just constructed here. As you prepare to walk into this interview, I want you to realize the sheer weight and value of the story you were telling.
It's a great story.
You weren't just going in there to recite definitions of CLIA regulations or the steps to the Z-track method or the normal ranges for blood pressure. Anyone who passed the exam can do that.
You are doing something much more sophisticated. You are presenting a cohesive, highly compelling picture of professional maturity.
You are demonstrating that you possess fresh, exacting, by-the-book clinical knowledge, but you are backing every single ounce of that clinical knowledge with 2 decades of tested, proven leadership.
You are looking the clinic manager in the eye and telling them, "I am the safest, most reliable, most resilient investment you can possibly make."
And as a final piece of coaching on your delivery, remember that the interviewer is evaluating your presence just as much as your answers.
The calm tone, the direct eye contact, the ability to sit comfortably in a high-stakes conversation, that all comes from your years of running a business.
Do not shrink yourself to fit the traditional new graduate mold. Lean into your posture as a leader. Let your 20 years of experience be the armor you wear into that room.
I love that. Wear the armor.
And to leave you with one final provocative thought to mull over as you do your final preparations. Think about the invisible toolbox you've carried with you all these years. Think about the countless times you've had to navigate a furious client, or rearrange a completely broken schedule on the fly, or soothe an anxious team member behind closed doors.
It's all connected.
When you walk onto that clinical floor, how might your specific, highly tuned radar for human behavior allow you to spot a crisis before it even happens? How might you naturally de-escalate an anxious patient or smooth out a scheduling bottleneck before the physician even realizes there was a problem to begin with?
You possess a level of operational anticipation that they don't even know they need yet.
Go in there, own your entire background, and show them exactly who they are hiring. You are going to be phenomenal.